జాగ్రత్తగా చూసుకోవాలి. దాని గురించి చెప్పడానికి ఇవాళ మన ఉన్నారు డాక్టర్ సుధీర్ కోగంటి గారు. డాక్టర్ గారు చాలా మంచి పేరున్న పెద్ద డాక్టర్ సిటిజన్ హాస్పిటల్లో పనిచేస్తారు. మనం ఇప్పుడు డాక్టర్ గారు చెప్పేది జాగ్రత్తగా విన్నాము. థ్యాంక్ యూ సో మచ్. ధన్యవాదాలు. సో ఐ రిక్వెస్ట్ డాక్టర్ సుధీర్ టు డెలివర్ ద టాక్. థ్యాంక్ యూ.
Good afternoon, everybody. It's a real pleasure to be here this afternoon, and I thank you, Jainji, very much for arranging this talk, and also Madam Tara Sharma for also having invited me over to give this talk. Thank you so much. So I hope this is going to be really productive for you for the next half an hour or so. What I'll do, most of these talks, wherever I give, I usually do it a lot of industries. Keep the talk brief, and then we have a lengthy Q&A session, because I feel that's where most of you benefit if you got any personal doubts and so on. So I'll just go through some useful tips and tricks, what actually causes heart problems and what we have in terms of advances in this day and age. And then we'll see. Yeah. So Jainji introduced me, gave an extensive introduction. So essentially, I graduated from FMC Pune, and is it on to? Yeah, I graduated from FMC Pune, which is run by Ministry of Defense, India, the only medical college they've got in India, which was a competitive entrance at the time. I think usually about 1 lakh people take the test every year. And then I moved to UK after that. Just to hone my skills, learn some advanced stuff. And then the plan was always to come back to India and serve India. So I studied at various places called Royal Stoke University, all big hospitals, university hospitals of Koganti and Warwickshire. Did all my general medicine training where I got my MRCP, and then went to Royal Free Hospital where I did my general cardiology training, Royal Free and University College London Hospital. In UK, the specialty training is quite long. Usually it's 5 years, but you have to do some research in between as well, like a dedicated research. So it's pretty long. Usually the DM in India is about 3 years, but in UK, by the time you become cardiologist, you're old like me. It was about 7 years. So I took 2 years out to do research at University College London, which is ranked 8th in the world this year. That gave me a degree, MD Res, but the research was on coronary artery disease. Really see, what exactly happens in coronary artery disease, who gets it, what happens inside the arteries, and then this was in Rotterdam. The research was actually in collaboration with Netherlands, so I spent some time in Netherlands as well in doing research and also learning about coronary artery disease. And then the best of the lot was St. Bart's Hospital in London, where I learned advanced coronary intervention, which is what I do day in and day out at Citizens Hospital. Between Bart's and coming back to India, I also spent some time at Papworth Hospital, which is one of the first hospitals to do a heart transplant in UK in learning heart transplantation. And my plan is to set up Citizens as a heart transplant center eventually, if that ever happens. And then this is obviously Citizens Hospital. So what do we do at Citizens Hospital? It's a tertiary level cardiac care, which is very close to you. Hardly 10-minute drive from here. We do all sorts of emergency procedures, particularly heart attacks. People come with heart attacks day in and day out, in the nights as well. And they need timely treatment in terms of what we call primary PCI procedure. That is, you have to put in a stent to open up a blocked artery as soon as you can. And we do that in a timely fashion at the Citizens Hospital every day. And then we do other advanced procedures as well related to heart failure. And but that's least important. The most important is preventive cardiac care. I think we should actually stop people from even getting cardiac disease. So we run a quite aggressive health package program wherein most of the software companies are tied up, and usually on the weekends, which is the Saturdays, they come and get their health check by going through an extensive package. And that is where we pick up if anybody is at risk of developing any heart diseases and screen them and treat them and with a view to prevent any long-term issues. So why is heart health important in 21st century? We discuss that, and then we will also look at what is it that we can do to improve heart health, and then what are the advances in heart health. So let's spend 10 minutes each on each of these, and then we can have question and answers. So it is important because there are significant societal and financial implications. The reason why I say society is if anybody young has a heart attack and is suffering with it and leads to loss of job or life, the implications on the family are paramount, right? And likewise, if for any reason, if that particular individual does not recover well and go on to have advanced treatments over a period of time, the financial implications are huge. Not everybody's got insurance. Not everybody got lakhs and lakhs of insurance, right? So not everybody can afford really costly treatment. So it's got huge implications on that. And then we need strategies to improve heart health. It's not uniform across the country. You know, I have a strategy at Citizens Hospital, but that doesn't mean the strategy is replicated all across the country. And we need this to improve outcomes. So whatever we do, we need to do in a timely fashion. If we do preventive care, we need to ensure it doesn't lead to long-term bad outcomes. On the other hand, if somebody comes with a heart problem, you need to treat it in a timely fashion so that they have good outcomes in the long term. So this is a leading cause of death. Over the next 4 or 5 slides, I'm going to show you, I'm going to convince you cardiac disease are the leading cause of death across the world. So this is in low income countries, which is infections essentially, and neonatal conditions, like in African countries. Third is ischemic heart disease, which is the heart disease. When you look at leading cause of death in lower middle income countries, ischemic heart disease, that is heart disease, the top killer. So annually, almost about 3 million deaths happen because of coronary artery disease. And they seem to be increasing. It seems to be increasing every year. When you look at middle to high income countries, again, it's the coronary artery disease, ischemic heart disease, almost 4 million deaths. And when you look at high income countries, it is ischemic heart disease. So apart from low income countries, which is African countries and maybe some Southeastern nations, most of the other countries, including us, the leading cause of death due to disease is ischemic heart disease, which is due to heart, almost 4 to 5 million deaths per year. And bear in mind, in India, we don't have robust data collection. So it probably is even more than what I'm showing here. And looking at trends in India across various states, this is overall cardiovascular disease. Anything in red is over 5,000 per million population. So Tamil Nadu and Kerala are highest, and then along with Punjab, and then comes Telangana, Maharashtra. When you look at ischemic heart disease per se, again, those 2 states, Maharashtra, Punjab, are higher. When you look at stroke, that's a brain stroke. Bengal seems to be higher, and then the coastal states here. And when you look at rheumatic heart disease, which is slightly different to the coronary artery disease, this is a disease which affects the heart valves from childhood infections, is still quite prevalent in India, and it's quite high all across the country. So you really need strategies based on these, based on this data, and individualized to the state to have good outcomes. And when you look at risk factors, 2 I'm depicting here. One is high blood pressure and also high cholesterol. High blood pressure is a bit more prominent in the north, and high cholesterol is prominent in Himachal Pradesh, Haryana, and again those two southern states. So again, but bear in mind, this registry may not be accurate, maybe even more than what I'm showing here. So there's one study, I'm just quoting one study here, which is called PURE study, a big cohort of almost 24,000 people from India. You can see the coronary artery disease events in Indian population is higher than the Western population, almost double. In the West, it's about 3.99 per thousand person years. In India, it's almost 6.43. It's almost double. So what is this? What makes us prone to these heart diseases? You've seen the PURE study. We definitely seem to be, South Asians, particularly Indians, seem to be getting more heart diseases when compared to the West. Why is that? So one study, which was published in a reputed American journal, has shown, so it's a comparison between South Asian and Caucasians. Age is younger. We're almost getting heart disease a decade earlier when compared to the Western population. We exercise less. We eat less vegetables. We think we eat more vegetables because there are more vegetables, but we seem to be eating less vegetables. Waist to hip ratio is very high. That means we're all carrying excess amount of fat, more diabetes, more hypertension, some cholesterol, dedicated cholesterol markers, which make someone prone for heart disease is more favorable in Caucasians. And depression and stress is also very high due to our unfavorable work life. I mean, what is this here? Monday to Friday, usually you work, or Monday to Saturday? Monday to Friday. Saturday, yeah. 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 So in UK, it's Monday to Friday. And I think most of the software too, Monday to Friday. But I don't know, they still complain of stress. No, not us or doctors. Yeah, related to work. And then let's look specifically at Indian numbers. It's definitely leading cause of death related to cardiac diseases. Presents a decade earlier, like I've shown in the previous slide. It's 23% versus 52% when compared to Caucasians. It's the other way around, sorry. And 25% of all deaths are due to cardiac diseases. That's almost 1 in every 4, 1/4. And then when you look at median deaths, it's 270 per million when compared to 235 per million in the West. So it's quite high in India. So what do we really do to improve? For that, we really need to understand what is the gravity of the problem, which we already did. We looked at those numbers. And we need to understand what are the root causes. Why do we get cardiac diseases? So that we need to understand that. Then we can prevent it. So this is an elegant study called Interheart study done by a gentleman called Salim Yusuf, who's a doctor from Bangalore who settled in Canada now. He did this study from Canada. He recruited people from 52 countries across the world. Really good study. And he's the one who's shown these are the risk factors for cardiac diseases. Which is smoking, diabetes, hypertension, the apolipoprotein levels, all 4, obesity, physical activity, and all risk factors. All of these are present. So very elegant study. This one slide is just enough to convince you what actually causes cardiac disease. If you have just one risk factor, right, odds ratio, that means the percentage of somebody having a heart disease with risk factor is 3 times almost when compared to somebody who does not smoke. So like that, if you take individual risk factors, it's okay. It's high, but not too high. But when you have all 4 risk factors, look at the odds ratio. It's 42 times when compared to somebody who doesn't have any of these. When you have all these risk factors, it's 330 times the risk of somebody having heart disease who does not smoke, does not have diabetes, does not have blood pressure, exercises, and is not overweight, is almost 300 times less likely to have heart disease. So this is it. This is the take-home slide. Essentially, we should not get any of these. If we have any of these, we should, say, for example, smoking, stop smoking. Anything else, aggressively control it. So same slide, when you look at everything included here, the diet is included and the alcohol is included. And when you have everything, it's 330 times more likely to have heart disease than anybody who doesn't have those. So the solution is simple, right? Smoking, stop it. If you're struggling to stop it, there is help available. I mean, there's a lot of my cardiac patients who had a stent, they struggle to stop smoking. So what I do, I give them a nicotine patch. So once you put a nicotine patch, they get the nicotine, so the addiction is gone, and then the habit of putting something to the mouth goes away over a period of time, then they are free of smoking. So we really need to take a holistic approach in helping them rather than just telling them you need to stop and scolding them. It's a disease, we just have to help them. Hypertension, agree, there are tablets, doctors are going to prescribe tablets to control, but what can you do from your side? Very simple, eat low salt and exercise regularly, right? And aim for a blood pressure of 130 by 80. A lot of people come to me and say, 150 by 100, it's okay, right? I'm 50. No, it's not. The guidelines keep changing because any amount of high blood pressure leads to bad outcomes. So 130 by 80 is the recommendation now. And a lot of people again ask, do I need to take tablet? If I take, am I going to take this tablet for life? It's important to take the tablet so that you're not going to have any bad outcomes because of high blood pressure, such as stroke or a heart attack. Because most of these tablets are pretty safe and nobody is going to get used to it. If your control is really good, we can always stop the tablet. And it's important you control this aggressively earlier with tablets and lifestyle, because you know what happens over a period of time if you leave blood pressure uncontrolled for say 10 years or 5 years, the arteries where the blood flows, they become like lead pipes. They're supposed to be elastic. Once they become like lead pipes, it's very difficult, even difficult to treat them. Even if you add more tablets, it's not going to help. And diabetes, we know, diet and aggressive control with all the drugs which we have, but lifestyle again is very, very important. Sticking to the diabetic diet and exercising regularly. Sometimes people come, they're all 3 drugs, insulin, still it's very difficult to control, and they're carrying a lot of fat around. If they exercise and lose all the fat, there's this concept called insulin resistance, because if people have got a lot of fat, insulin does not act. So if you lose fat, then insulin again starts acting, and the sugar level starts to come down. And as a result, any cardiac disease or any brain-related disease secondary to diabetes, we can control. Obesity is self-explanatory. I think we just need to watch what we eat. It's very difficult, I know, to control with Swiggies and the Zomatos. But I think we should stick to the home-cooked food and exercise. Okay, and then psychosocial. I'll show you a slide where a gentleman is working on laptop while somebody is driving on a scooter. I think we should really, it's important to work, but I think we really need to know to de-stress ourselves as a, be it a sport. I think you cycle or music or yoga or meditation. We need to have a free pastime. I have a colleague, you know how he de-stresses? Any new movie, he goes for a second show. And next day he comes back to work as usual in the morning. So I think that's important. We all have our own way of de-stressing, whether it's playing something, badminton, cricket, whatever. Okay, and that goes to exercise as well. And I think fruit and veg is self-explanatory. Despite of a predominantly vegetarian nation, India being a vegetarian fruit and veg consuming nation, we're still eating less fruit when compared to our Western counterparts, because I think we eat a lot of carbohydrates along with the vegetables, whereas they eat a lot of vegetables as such for salads and things like that in sandwich for lunch and so on. So I think we need to eat more fruit and veg. I know there are some videos going around recently telling to eat less fruit because it's got sugar. It's fine. I think natural sugars are much better when compared to the artificial sugars like your Domino's and McD's. Okay, what else can we do? I mean, so it's great to preach. But what else can we do? I mean, I think it needs to start from within ourselves at an individual level. We need to be motivated. We need to have the degree of self-motivation to take care of our health. Okay, I think it should start within us first. I mean, a lot of people tell, in the last week, are you walking? No, it's raining. No, I'm not walking. So, but I'm sure, I mean, you can exercise cycles in the house, you can get a treadmill in the house. There are various ways of exercising. I've seen people walking in the basements in my community. I mean, it's such a hazard, I can't drive. When I go to park, I'm worried I'm going to hit them. But some people are, we have extremes. Either they go out or they don't go out at all. And then peer groups is a fantastic thing. I think we need to, anybody who's trying to lose weight. I mean, we are such a social, gregarious nation. We have people everywhere. Very easy to make friends. In the UK, I was like, you go on a street, you don't see anybody, nobody to talk, right? But we have so many. I mean, I think make a group, make a group who's got similar interests, like playing badminton every time of the day, the same day every week, or cricket, or some sort of activity. I think peer group is fantastic. So you can then have set goals, compare with each other, and motivate yourself and also the group. And then at an organization level, so for example, NIAB, I think we need to have awareness at an organization level. Maybe we keep sending some sort of flyers regularly or conduct activities. A lot of organizations conduct sports, marathons, and such. I think we need to have some sort of initiative from organization level as well to have this, awareness about heart health. And then I think the most important and the least concerned of the whole list is the government. They're not bothered, but I think they also need to change in terms of policies and also implement those changes. I mean, they've done banning public health place smoking, but that's not enough. I think we need to do really more. But this public health ban smoking, I'll tell you an example. What happened in UK over the last decade, the number of stents being put into people plateaued once the public health smoking was banned, and it was enforced quite strictly. Anybody who's found to smoke on the streets was fined, so they just stopped. So I think we need to have such sort of initiatives as well. I think one such initiative probably is low salt. Right? I mean, nobody talks about low salt anywhere. The salt, the sodium, so we take salt for sodium and also for taste. That's it. There's nothing else. The sodium is actually which we consume from all the rice, the fruit, the veg which we eat. It's got required amount of sodium. We don't need any extra amount of sodium, but nobody talks about it. I think it probably needs to come from really high level, and also even the FMCG companies like ITCs, the HUL, they need to take initiative as well in cutting down the salt. I think it needs to, we need to change at quite a lot. So this is the guy who's working on a laptop. This I saw on my Twitter last night. So somebody is driving, I think, and is working on his laptop sitting at the back. We really don't have to be that stressed, okay? So that said, I'll just touch on 10 minutes what we have in terms of advances in heart health. I mean, we're really making fantastic strides in terms of offering advanced health, even in everywhere, even in this part of India. But my point is really it should not come to this level, because once it comes to this, you can never go back to normal, and it gets very, very expensive, as I'm going to show you in the next few slides. There's a lot of clinical studies that are happening, and it's happening from your side as well in terms of research in developing drugs, vaccines. Phenomenal amount of research is happening in terms of cardiac health all over the world on how to improve outcomes. And there is continuous education. I mean, once you're a cardiologist, it's not done. You need to update yourself because the technology is changing every day. You really have to update yourself to offer the best care to your patient. So there's virtual and physical conferences now that COVID is hopefully firmly behind us, unless the monkeypox kicks off. So we do have next generation of cholesterol lowering medications. I'll just spend a minute on cholesterol lowering medications. There's always a bad press about cholesterol lowering medications, particularly the statin group of drugs. They're really good in improving outcomes, period, okay? Because of all this bad press, even people who's got heart disease, they stop taking these important drugs and they come back with further heart attacks. You would not believe in this week, the people who already underwent stenting, who underwent a repeat stenting with me were about 3 or 4 because they were non-compliant with medications for various reasons, particularly bad press. But taking a tablet every day is difficult for people, and also taking a tablet every day may not be enough for people. So there's research ongoing all the time, And we're into this era of injectable cholesterol lowering medications where you can just give this injection once every 2 weeks and that will take care of cholesterol. But this is usually on top of the statin, okay? But that's expensive. And then you all understand what inflammation is. And the root cause for cardiac disease is inflammation. And studies have shown by using specific anti-inflammatory drugs, you can prevent long-term cardiac disease. We can do heart valve replacements without even opening the chest, right? We can just put a valve in somebody's heart like a stent, okay? This is nothing to do with lifestyle, but this is age of the elderly. Most of our parents or grandparents are really living into their 80s and 90s. So by nature, they're going to develop deformed heart valves, and we can replace those without opening their chest. So they can walk home in 2 to 3 days when compared to surgery, where they go home after 7 to 10 days. And they're at much higher risk if they were to undergo cardiac surgery. So this really changed the landscape for people who are elderly. So about 10 years ago, any older patient with a heart valve disease, we used to just take tablets and stay at home. They really used to have a miserable quality of life due to symptoms. But with this, it has changed. I mean, they can go out, they can start walking and so on. But again, this is expensive. And then we have transplants. You know, more and more heart transplants are being done. We're also catching up. We're really slow, but this is where the government need to play an active role in raising the awareness, because it's considered a taboo. Anybody who dies, what a waste of organs. I'm not saying it in a lighter vein. In UK, if somebody dies, I think there was one example where one gentleman's organs went to about 9 people, including the cornea, lung, liver, heart. In India, there is a huge taboo. You know, people think if somebody donates their heart for transplantation, there is a belief that in the next life, they are going to be born without the heart. So there's a lot of these taboos. So we really need to raise awareness among these people. And I think government is going to need to play a very active role. They are switched on. They help with green corridors. You might have heard about green corridors. When you're transporting an organ from airport to a hospital, they clear the roads and things. So they are putting in an effort, but we need to do more. In somebody who is not fit for transplant for various reasons, then there are assist devices. So you can just implant this device and they carry on. It's a device that is attached to the body with a battery, and it takes over the function of the heart. And they can live with this for long. In US, they're pretty much using this for what we call bridge to destination, like because they don't have that many hearts to transplant into people who need it. So that's why they use these assist devices, but ridiculously expensive, very, very expensive. This happens probably once every year in Hyderabad. So prohibitive cost, that's a reason. And then we have various ways of improving training, simulation. I'm sure you're probably aware of simulation to learn stuff. And then we have 3D printing to understand the anatomy of the cardiac defects and treat. And then virtual reality as well, where you don't need all this hardware. You just need one headset and you can train yourself in not only cardiac diseases, various other diseases. I'm sure you must have seen virtual reality in all the gaming zones, right, where you play cricket with it, but we do much better things with those. I've even developed one concept. You know, when people come for angiogram and stenting, they're really anxious, right? But you don't want to, these procedures are done under local anesthesia. You don't want to give general anesthesia to them because the recovery is very fast. You want it to be fast. So I took a headset and put in some nice music with visuals as if you're on a beach or you're in a forest. And whenever they go on the table, I put the headset. So they're not looking at a blank screen. They're actually looking at a nice visuals and listening to a music. And the procedure is done in 10-15 minutes. It's so calming for them. So I presented that study at TCT San Francisco. It's really kicking off now. People are using this for even slightly longer procedures. And then artificial intelligence and machine learning. I think this is going to play a huge role going forward, because like I said, I do a lot of health packages, but we need to identify patterns in them. Who's going to get heart disease? You know, it gets boring because you just look at reports every day and everything is normal, but still these are the people who are going to get heart attacks in future, heart disease in future. So we really need to identify patterns. And I think that's where AI and machine learning are going to help us going forward. This is the future. And then we got robotic cath labs. Now I don't have it. There's one or two in India. This is going to change the landscape significantly. Yesterday I was in cath lab all day, and somebody comes at 5:30 and says, "Can you do my pulse procedure now?" I mean, there was no urgency in that, and I was tired because when I do these procedures, I'm standing in the cath lab, putting on lead shields, protecting myself from X-rays. It gets really, really tiring. If you have robotic cath lab, you don't even have to go into the cath lab. You just need to sit outside and just play like a video game. So that's on the horizon as well. And then I think this is fantastic. This slide, please take this home. Wearable devices. This is going to change the landscape completely. We all have Apple Watches. How many of you are going to use it for heart rate monitoring? Hands up. 3, 4, 5, right? So you can do a lot of things here. You can do heart rate monitoring. You can use it for detection of arrhythmias. So some of your grandparents, they always complain of palpitations. Dil mein dhadkan ho raha hai, and we never take them seriously, right? The old man's telling something, but usually it's because of some sort of heart rhythm problems. So fit a wearable device to them and monitor the heart rate, and if it really goes to 200, they're serious. You need to get them checked over. Exercise tracking, you know, all the amount of calories you're burning, number of steps you're taking, everything. You can use the apps to record diet, all the dosas and everything which you're consuming, count the calories. I once got scared. You know how many calories there in one vada? About 200. And you know how many times you need to walk, how many kilometers you need to walk to burn that? About 3 kilometers, I think. Yeah, and so on. And then sleep monitoring, because good quality sleep is very, very important. You know, your 7 hours uninterrupted sleep every day is going to solve a lot of problems, including weight, blood pressure, sugar as well. Very, very important point that is. And this slide just showing what all you can do with wearable devices. I think during COVID, people were using it to measure the oxygen saturations, all those things. I'll just tell couple of cases and then we'll conclude. I was just telling ma'am in her room about these 3 cases. All are 31-year-old, pretty similar age, right? All these people had heart attack this month. And one gentleman came in really bad shape, but timely intervention really saved him. And they're all recovering, they're all doing really well. But you know, the common denominator is smoking and overweight. They're only 30, but they're really, really huge, and they smoke. I just want to ask, are you all CPR trained? Do you all know what you need to do if somebody have a cardiac arrest in this campus? Yes. I think that's probably a good initiative, so that if somebody arrests somebody, the most important thing is to do immediate CPR and get their heart rhythm back, and then you have time to take them to hospital. And then these are some other people who I've treated over years, and this gentleman really came late after heart attack because he thought it was all gastric. And I think any doubt, seek help early. Don't Google it. We have this, I think there was something called idiot syndrome, right? Internet derived something. I can't remember the name of it. They read Google and they treat themselves. He needs transplant now. Whereas look at this man, 82-year-old, identified heart valve problem very earlier. I did the aortic valve, which I showed you at the time of Sankranti in 2019. He still comes follow up after 3 years. And this is the lady, 106-year-old lady. whom we did emergency angioplasty, and she lived on for another 3 years. She's no more, but she lived till 109. Thank you so much for giving me this opportunity. And these are my social media, IDs. If anybody wants to interact, you can do that. But I'm happy to take questions now.
Yeah.
Thank you very much, sir, for the talk. I want to know how to identify a person if he or she is undergoing heart attack. Like how to differentiate between normal heartburn or acidic reflux and cardiac arrest. And my second question is, like nowadays below 30 also people get heart attack. So for us, what would you suggest? Like should we go for cholesterol checkup in every year or once in 6 months? So what would be your suggestion?
Sure. Thank you so much for those questions. Firstly, like I said, don't try to self-diagnose. If you're in doubt, seek experts' help, because we can identify whether it's heart-related or not within 5 minutes. Okay, but for general understanding, gastric issue usually is burning in nature, right? And usually related to food. It happens after you eat it. And it starts in the stomach sort of area and builds up right in the center and goes to the throat. Right? You may even get that acid sensation in the mouth. Okay. Whereas heart-related pain can happen anywhere between abdomen, umbilicus, to the throat on either side. It doesn't. Heart is here. It doesn't mean you're only going to get pain on the left side. It can be center, right, left, anywhere, because of the dermatomal distribution of the embryological development. As the body develops, that's how it develops. So you can get pain anywhere here. Okay, and tends to be exertional, right? Cardiac predominantly tends to be exertional in the early stages. Gastric also can happen with exertion, but usually not, right? Gastric is usually not associated with sweating and breathlessness, whereas your cardiac related is usually. You can have vomiting sensation with both. One very important point here is symptoms tend to be slightly different in females. So all the characteristics which you mentioned of cardiac pain are typical for males. Females tend to be slightly atypical. Fatigue, more nausea, vomiting, dizziness, that sort of thing. Basically, if you doubt, get tested. Okay, but usually in females, till about menopause, there's a production from the hormones, right? But after menopause, the risk is equal for both men and women, unless you have risk factors in terms of diabetes or smoking. So that's the first question. And the second one is younger generation. Like I showed you in those slides, there is a reason usually for these people having heart attacks at a younger generation. Either have a strong family history, they're obese, their diet pattern is really bad, or they smoke. If you don't have any of those, and if you don't have any of the symptoms, don't worry. Just maintain a healthy lifestyle. If you have any of those, then I think we need to look more closely and screen them properly by doing LDL cholesterol and also that apolipoprotein levels. Okay. I think there's a lot of people who, if they want to ask in Telugu, that's fine too.
Hello, sir. We know that physical inactivity, obesity, and smoking causes cardiac disease. How does that?
Oh, you mean what is the mechanism? Yeah. So obesity and lack of exercise and bad diet is going to lead to high cholesterol levels in the body, right? And then there are various types of cholesterol. And the bad cholesterol usually gets deposited in very important places of the body, like heart, neck, and the brain. And once the cholesterol accumulates in the heart artery, there is not enough space for the blood to go. That's why they have a heart attack. Smoking is slightly different. Smoking usually leads to, bad diet, alcohol, that sort of thing. But the predominant mechanism in smoking is it damages the inner lining of the blood vessels, the arteries. So normal arteries have got these endothelial cells, like you all know, right? That is protective. The endothelial cells does not allow anything to accumulate. But once that's endothelial, the gap junctions, the endothelial cells damaged, then cholesterol can go in, and smoking actually promotes that. It damages the endothelial cell line. Physical inactivity is the same. You're not burning the calories, so you're building up the cholesterol inside. And there's one other important thing. If you do physical activity regularly, even if there is a, say, 50 or 60% block inside the heart, right? The oxygen demand promotes what you call, vascular, what is the term? Help me. You're all science students. What arteriogenesis? Yes? Neovascularization, that's the word. You develop the collaterals, okay? Some people call it natural bypass, okay? So what happens when you develop collaterals, one of the arteries which got a block is going to receive extra blood from the other side. So that's going to help you if you're physically active. And your body is prepared for it. If you're physically active, your body is prepared for any adverse events. If you're inactive, you're not. And when you're physically inactive, you're going to put on weight. You're going to deposit fat all over the body, and that promotes diabetes.
Next question is CPR is only for cardiac. So how do you differentiate cardiac and heart?
So you need to have proper training in whom to do CPR. Okay, sometimes people may just faint, and if you do CPR, they're going to hit you. Okay, so you need proper training. Cardiac arrest is different to heart attack. Heart attack means you're having, like I said, there's no blood flow to the heart muscle, and you're getting chest pain. That is heart attack. Cardiac arrest is because of this heart attack or for various reasons, the heart stopped beating completely. Okay, two different things. Heart pain is okay. చాలా కామన్ గా జనరల్ గా మజిల్ పెయిన్స్, గ్యాస్ట్రిక్ పెయిన్స్ ఉంటాయి. ఓకే, కానీ మీరు కనుక నేను ఇందాక చెప్పినట్టు ఆ మిడిల్ ఏజ్ లో ఉండి ఇంట్లో ఎవరికైనా హార్ట్ డిసీజ్ ఉంది, సిగరెట్ స్మోకింగ్, షుగర్, బీపీ ఇట్లాంటి ప్రాబ్లమ్స్ ఏమైనా ఉంటే మాత్రం చెక్ చేయించుకోవడం బెటర్. సెల్ఫ్ డయాగ్నోసిస్ వద్దు.
How much time of physical activity is good enough to maintain a healthy heart regularly? My first question. And second is what the particular blood test or whatever to be monitored regularly again to maintain a good heart?
Okay. I'll answer this like this. The European Society of Cardiology, who gives guidelines for all of us on how to treat. You know what they say about right amount of exercise for a heart patient? 30 minutes of aerobic and 15 minutes of strength. So almost 45 minutes. That is for a heart patient. For a non-cardiac patient, if you're fit enough, there's no limit. If you want to do walking for 1 hour, you can do that. If you want to play for 1 hour, you can do that, and so on. But generally, just be a bit careful in terms of, you have this target heart rate concept, right? Just stick to that. And as long as you maintain your target heart rate for about half an hour to 40 minutes, that is more than enough. Okay. And what is the second question? Yeah. For anybody who's over 40, every year ECG, echo, treadmill test, and cholesterol levels, sugar levels is probably recommended. Anybody over 40, not under, unless they have the risk factors, like I said. New arteries, you mean?
What is your take on that? Is it a part or does it really work?
Yeah. So my brother-in-law, who I did an angiogram, and he's on medical therapy, right? But from time to time, he keeps sending the same message in various languages. Maybe he thinks I'm demented. He says, "What is this ECP?" Sudheer, I came across this clip. It's even now I didn't respond to him because I think he's taking, he's really insulting me now. He always asks about ECP, which is the natural thing. ECP is reserved for people where we can't do anything by any other means. Okay, so in medical therapy, somebody's got bad heart disease, bad blocks. You can't treat with tablets, no stents, no bypass. All the options are exhausted. Then it's ECP. ECP is not the first line. But unfortunately, this is again where I think the government should step in. There are so many unscrupulous practitioners telling ECP is a magic and charging huge amounts of money from people. It doesn't work. I'll tell you my first-hand experience. We did a study called ERIC PCI study while I was in UK. Essentially, what we did was anybody who came in with a heart attack, we used to put a blood pressure cuff and keep inflating and deflating, because you're thinking all this by deflating and inflating, you're changing the blood pressure, you're stimulating the atherogenesis, the arteriogenesis. And that is the concept for ECP as well. That was a failed clinical study. And none of the guidelines recommended. But we reserve it for people who are really suffering and there's nothing else, then we offer it.
Any other questions, please? Yeah.
They've got a role, yes. They've got a role. For example, these wearable device is a fantastic one. Before wearable device, we used to implant devices inside. You know, sometimes people keep collapsing. It happens once every month. It's really difficult to monitor them. So we used to put a device inside the body. But with wearable devices, you don't need it. Pacemakers are usually used for heart rhythm problems anyway, but you can use those for monitoring as well.
So I request the director madam to say a few words.
Thank you very much, Dr. Chair. Well, on behalf of all of us and on behalf, really thank you. This is a very good evening when we are all here, and most of us, as you say, we know many things. Some of us, we really just practice, do it anything, you've got to catch up 15 minutes walk, or 10,000 steps,
Yeah.
whatever. And some of us, as you said, it's a rainy day, we call that. And I think that's it. So I just say a small thing. I was also kind of many times a rainy day time.
Yeah.
Then my elder son taught me, see, however busy you are, just if not 40 minutes, grab 10 minutes. So what do you say that people who work basement and all those? But there is a flip side. I don't know, I'm not the one, but you are the one who can really say. But there's also a flip side where people they crazily continue doing it, that morning 1 hour, evening 1 hour. I think that also, I don't know, how would you comment at it? And there, I found that we had a colleague back at the place where I was working previously. He would walk very fast and all the morning workers, he just walk into and then evening again, leave office and again he walk. And then we find that he was in hospital and with all three stunts and people, everybody, whoever is going, hey, you were a vegetarian and you were not consuming the alcohol and you were the fastest walker among us. So, I mean, the point I'm sharing is everything optimally, I think physiologically is the key, perhaps you are also trying to say. And I really appreciate you saying things in a very simple way. And I thought that maybe you'll elaborate few more things, but you did put it in a very simple way, asking not much and telling people in a most like simplest. what is that? Low sugar, low salt and all. And you explain, and I think people, majority, more than 80% people, they all understand what sodium. And as about fruits, you say, that's right. Dr. Area can recall over one dinner, we were just talking about it. And yeah, that's also. So I think, as very rightly the doctor said, the accomplished doctor qualification was. I really, that's a truth. Do Google for right things, but everything what we Google is not really good. And this WhatsApp school is kind of in its own way, as you're saying. So that is all. Because you are here, so we are revisiting and discussing it back again, what probably all of us know. And going hand with the accomplished cardiologist, that let's try not to that rainy day kind of question.
Yeah.
It's one pleasant evening, and it's wonderful that you put your time out, and good that all our colleagues and faculty and employees are here, students, fellows. Wonderful.
Thank you so
very
much. Thank you for coming.
Thank you, madam. Thank you so much. Thank you, Dr. Sudheer, for such a wonderful presentation. And big round of applause to Dr. Sudheer for his time and valuable information. I request Director Madam to present token of appreciation on memento from our institute to Dr. Sudheer.
Yeah.
And that is our signature memento.
Thank you, madam. And thank you, Dr. Sudheer. Dr. Sudheer is accomplished cardiologist and he is very much available. He has given all his contact details here. He is presently with Citizen Hospitals. If somebody's family member is having some issues, you can contact Dr. Sudheer, of course, with proper appointment, not like directly we are going. But he is a very nice and very gentle person. I know him as a doctor, and he is really, really helpful. Means if somebody is having some problems, they can definitely contact him. He will be a good person who is giving a very rightful and very appropriate advice in cardiology. So thank you very much once again. Thank you, madam, for your time. And I request all that we are breaking for tea. Snacks is available outside this auditorium. Thank you very much. Thanks.